What's going on, guys? Sitting in the reading room. Obviously, you know what the title of today's talk is. Intro to chest X-ray. Everybody's wanted it. Got a lot of comments, a lot of messages about doing an intro to chest X-ray. So here we are. I got a live case for you. Well, it was previously, at least at one point. Everything's anonymized. All the patient indicators are all off, and I got a PowerPoint presentation with some common questions that you're gonna see. Dr. Justin already says rule number one, everybody has atelectasis. That is absolutely true. If you're in the hospital, you're probably short of breath, you probably have some atelectasis. Let's see, how do I turn this camera back around now? All right, so we're in the reading room. This is a cardiac room. This is where we do all the cardiac studies. Just a quick brief thing on that. Cardiac is one of the most high-end things that we can do. So I'm using their computer today, which is nice. So you guys saw the chest X-ray, or the title. It's Intro to Chest X-ray. That's what we're gonna be doing today. Once again, for people who are joining right now, I do have a case that we're gonna go through completely. If this were a case that I were to pull up on the fly, it's a live case. I'm gonna go through exactly what I would be looking for, exactly how I would dictate it, all that good stuff. I actually am on call today, starting in about an hour and a half, so I'll probably have a lot of chest X-rays to read. Let's go over real quick. The radiology guy says rule number two, atelectasis could be infiltrate in the appropriate clinical setting. Absolutely. Rule number three, Dr. Justin, clinical correlation required. Rule number four, probably should get the CT. Don't get the CT because then I got to read the CT. Let's just call it off of the chest X-ray, pneumonia, atelectasis, and move on because I don't want to dictate a chest CT, all right? So, should we just get right into it? I think so. Let's turn the camera back around. Everything should be in normal anatomic position. I don't think anything will be turned around. Money in the bank, that's what I'm saying. RVUs, right? This is all RVUs. All right, so we got a chest X-ray. It's a frontal and a lateral view right here. So L, left side. These are just from the tech who did that. All right, so here we go. I pull up the chest X-ray. I look at the indication. It's toe pain. I'm not joking you. You can get a head CT and it'll be toe pain. You can get an abdominal CT and it'll say brain hemorrhage. So the chest X-ray, if I'm looking at the indication, I'm not really banking on too much what the indication is, but it's probably short of breath, probably chest pain, something like that. So I open it up, I see this, all right? So now I start looking, I'm like, all right, let me get just a general gestalt. That's one of my favorite words when you talk about radiology and medicine. Let's get a general feel for what the chest X-ray looks like. I think it looks okay, not too bad. I think the lungs are pretty well aerated. Once again, I'm not gonna start counting ribs. I'm not gonna start doing all that good stuff that I know people wanna ask me about right now. Again, I'm just getting an overall feel for it. And then the second thing that I'm gonna do is I'm gonna say roughly how old is this patient? What can tip that off, or tip you off about how old this patient is? I start looking around. Nothing too much is indicative around here, but then when I go to the bone, I see that these growth plates are still wide open. So I'm like, all right, this guy's not too old, not too young. I'll give him about a teenage status. And I look on the other side as well, same thing. So, okay, I'm looking at about a teenager right now. Probably, if I look over here, maybe a male patient. I don't see any breast tissue, but we don't know at this point. So now I'm gonna say, okay, let's get straight down into the search pattern. If you're a surgeon, I have seen surgeons, they want to know select things and emergent things when a trauma patient comes in. I know some people have heard the ABCDs of a chest X-ray or the ABCs of a chest X-ray. I do it a little different. I'm doing a thorough search. So here's my radiologist way of doing it. Once again, if you guys have tuned in before in my live sessions, you know that I harp on the fact that the body is mainly symmetric, right? There's some exceptions to the rule, with the liver and spleen, but for the most part, you have one thing and the same exact thing on the other side. So I'm gonna use that to my advantage. Let's start off with the lungs, right? That's the moneymaker. This is what everybody wants to see. Something's going on with the lungs. Oh my God, is it pneumonia? Oh my God, does he have a pneumothorax? What's going on here, right? So I'm gonna start off with the lungs. There are two lungs, obviously. different lobes, but I'm gonna start comparing side to side. This is, once again, this is the way I do it. If you wanna do it some other way, hey, more power to you as long as you get to the correct answer. But here's how I do it. I start off up here. This is a trouble spot, and we'll get into why. But this can be a very trouble spot for finding underlying malignancies, that kind of stuff. But I start from here, and I don't just go to one side, because what if I looked at this lung and it's fine, it's totally okay. But then I looked at this side over here, maybe it was so diffusely bad, but if I didn't compare it to the other side, I would call it normal. So what I'm gonna do is I'm gonna start here. I'm gonna say, all right, I see the density, there's good penetration, I can see through the lungs, and then I'm gonna go over here and I'm gonna do the same thing, and I'm gonna compare these two sides. And then I'm just gonna scan my eyes back and forth, back and forth. We're just gonna keep going, keep going, keep going. My rule of thumb when I look at chest x-rays, I'm all about lines and angles. And on my PowerPoint that I'll get to after this live case, we'll get to the PowerPoint, I'll show you exactly what lines and angles that I'm talking about. But I wanna see every single line very symmetric. I wanna see it very distinct, and I want my angles to be sharp. What angles am I talking about? This angle right here, right? Anybody know the name of that one? Once again, everything's symmetric, so there's one on the other side. So these angles are nice and sharp. I love it. What lines am I talking about? Look at the right heart border. That's a beautiful line. Look at that right hemidiaphragm. That's a beautiful line. Once again, for somebody who's not too familiar with chest x-rays, right, left. So remember, radiology, right side here, left side here. This is screen left, screen right. I'm not gonna say that. I'm gonna say patient's right. So the right hemidiaphragm, beautiful. It goes all the way from here all the way to the right heart border. Look at the left hemidiaphragm. It goes from right here all the way here. So we talked about this angle right here, right? Costophrenic angles, nice and demarcated, nice and sharp, beautiful. What about this angle right here? This is the cardiophrenic angle, beautiful, it looks good. Cardiophrenic angle looks good, right? It's nice and sharp, everything looks good. So just a real quick recap. I started from here, I went side to side, back and forth, went to the angles, look beautiful, went to these lines, looks good, looks good, looks good. And then I'm gonna make my way back up. All right, so as I make my way back up, I'm gonna start looking at these lines again. Left heart border looks good. I already know the right heart border looks good. I come up. Now I'm looking at the mediastinum. Yeah, it's actually pretty good. It's nice and probably within normal limits. I don't mind. Somebody may ask, how big is the heart supposed to be? Well, you don't want it about 50%. So if this is the width of the whole chest, you don't want it to be greater than 50% of that width. So now as I go up, now I'm gonna start looking at this. Anybody know what this is? This is the aortic notch. Some people may call it the aortic knob. I like to call it the notch. And you want to see this descending aorta. Look, another line. Again, I love lines on chest x-rays. So I see this nice sharp line right here. That's beautiful. Now I'm going back up and I see, what is this? This is the mainstem bronchus. This is the carina right here. The left mainstem bronchus. I come up. Nice trachea, everything looks good. I look at the hilar contours while I was around this level. This hilar contour looks pretty good. See this indentation? It's concave like that, right? It's not bulging out like that, because if it's bulging, you may think about other things like some sort of mass, some sort of adenopathy, maybe some pulmonary artery hypertension or enlargement, I should say. Look at the other side. The pulmonary arteries look good. So I made my way back up. And then the last thing that I look at are going to be the bones. I'm not too concerned when I'm initially looking at a chest x-ray for chest pain, shortness of breath, so I don't jump straight to the bones. Once again, that's just the way I do it. But bones now I'm looking at last. I look at everything. The clavicles look pretty good. Look at all the ribs. Everything looks good. The other thing that I want to stress upon, when you pull up a chest x-ray, you better not just read it if it just kind of looks like that and it's all hazed out and you're just looking at it in one view. If you ever sit with a radiologist, they are constantly windowing things. Their eyes are never happy just looking at an x-ray like this and looking at everything that they're trying to evaluate in one color. No, absolutely not. I am windowing everything. So I'm gonna window right here to this costophrenic angle. Then I'm gonna go to the other side and kind of window down. Looks pretty good. I'm gonna go to the, look at this trachea. Now I wanna make that trachea more distinct, or that mainstem bronchus more distinct. I'm kind of, really exaggerating the windowing here, but you get my point. When I'm looking at the ribs, I wanna really window down. Can you see these bottom ribs down here, the 12th rib, 11th rib? Can you see that when it's like this? Absolutely not. So what I want to do is I want to do one of these. Look at that. Now you can see the rib, right? Beautiful. See, now you can see the other side. Now you can tell me if there's a fracture or not. So window, window, window. This is not just chest x-ray. This is a head CT. This is an abdominal CT. This is absolutely everything. For any radiology residents out there, if you're reading a brain MRI and looking at the diffusion and you didn't window, you're missing strokes. I'm telling you 100%. All right, next thing that you're looking for, whether this is a trauma, whether this is a tall patient who's having shortness of breath, young, tall, male patient, start looking for pneumothoraces. And the reason I'm saying that is because they can be prone to getting a pneumothorax if their body habitus, is kind of going down that route. So if I'm looking for a pneumothorax, not always will you see a pneumothorax up here. That's if, it's upright and the air rises, right? Sometimes on your ICU patients, you won't have the pneumothorax up there. You'll actually see the pneumothorax kind of anterior. It'll only be, imagine somebody's laying down, the air is going to rise, so it's going to go up towards the top of the chest cavity. So that's harder to find. That's harder to diagnose. Maybe at one point we can find an anterior pneumothorax and I can talk to you about it. The other thing that I want to talk to you about, look at this hemidiaphragm. Notice that it stops right there. Look at this hemidiaphragm. Notice that it stops right there. If you ever see this hemidiaphragm going all the way, all the way, all the way, and you stop basically calling it a hemidiaphragm and it's just one continuous diaphragm, that's a buzzword, you have a continuous diaphragm sign. If you have that, so I could trace it all the way from here and go all the way to the other side, that's bad. It is your job now to figure out why do you have a continuous diaphragm sign. Whether it's abnormal air up here in the mediastinum or abnormal air down here in the peritoneum, it's your job to figure out where that abnormal air is coming from. But if something is abnormal because you have that continuous diaphragm sign. Next thing that I want to point out, which hemidiaphragm is supposed to be higher? I mean, you're looking at a normal chest x-ray right now, so this is what it's supposed to look like. Look at the right hemidiaphragm and then look at the left. This should be higher in, I'm making up a number now, 92% of your patients right here, okay? If the left side were higher, it's your job now to figure out why, all right? Is the lung collapsed? Is there loss of volume on this side and therefore it's being raised up? Or is there increased volume down here and it's being pushed up? So it's your job to figure out why. Is this down for some reason? Is something wrong with the liver? Is the patient cirrhotic? Who knows? Again, you need to figure this out, right? So we covered pretty much everything about this normal chest x-ray. We said the right hemidiaphragm is going to be higher than the left. Now, quickly, now that I mentioned that, which hyla do you think should be higher than the other? Well, it's the exact opposite of the right hemidiaphragm. So this hyla should be higher than this side. The other thing that I want to stress to you, the pulmonary arteries or the tiny little arteries, should they get bigger as you go down here or should they get bigger as you go up there? Normally, they're going to get bigger as you come down here. That's normal. There are instances where they get bigger up here. We can get to that at some point, but that's not normal. It may be normal for the patient, but there's something underlying going on that's causing it to do that. The other thing that I want to point out, I am just ranting off the top of my head right now because that's just what I do. But the other thing that I want to point out is look at this trachea. Everybody loves calling tracheal deviation. They love it, they love it, they love it, right? That's the first thing that your eye goes to. It's like, oh, hold on. The trachea is deviated. Okay, so here we go. Radiology pro tip 201 right now. First of all, normally, if the patient has a normal arch on this side, remember I said this is the aortic arch right here, the aortic notch, and here's the descending aorta, that's gonna normally cause the trachea just kind of be laying a little over that way. If you had deviation that way, well then start thinking about it, all right? Number two, everybody's favorite question, the attendings, when you're upstairs rounding on the medicine floor, they're gonna pimp you on this. They're gonna say, hey, is the patient's chest x-ray rotated? And you're gonna say, I don't know, maybe he's a little to the right. No, wait a second, maybe he's a little to the left. Here we go, Radiology 201. So how can you tell, right? You're not looking really at the trachea because the trachea can kind of move around. I'm looking at these spinous processes. Do you see these spinous processes right down the middle? You see these guys right here? And then I'm looking at the clavicular head. See that? That's one right there, and that's two right there. And basically, imagine, I'm gonna use my hands here, imagine this is one clavicular head, this is another, and these spinous processes kind of right in between my hand. Imagine now if the patient's rotated this way, Which way are the spinous processes? Which side are they closer to? Now imagine the patient's rotated the other way. Which side are the spinous processes closer to? That's how you figure out if the patient is rotated or not. All right, here we go. What else can we talk about on a normal AP? Oh, then somebody's gonna ask you, oh, here we go. Is this an AP view or is this a PA view? You're kind of like, I don't know, it's all shot from the front, right? It kind of makes a big difference. If it's an AP view, if somebody's in the ICU, they're just doing, patient's laying down, they can't stand up or anything. They shoot the X-ray from up front. They got the plate behind the patient, which is like resting against the bed in the back of the patient. Well, that's going to accentuate the heart border, all right? So if it's a PA, though, somebody's coming off from the street and, they're standing up and everything's shot like it should be, well, the heart border will be actually within normal limits or normal, and it's not really accentuated. The one way to really tell and kind of give you a hint as to, obviously, if it's written, then, hey, more power to you. But if it's not written, look at the scapula here. Do you see the scapular border right here? That's one. There's another one right there. First of all, know that this is the scapula, right? Because this can commonly be confused for a pneumothorax. This is not a pneumothorax. This is the scapula. So if you see a lot of the scapula, it's probably an AP view. But if you see very little of the scapula and the scapula is actually way back here and the shadow's all the way over here and the shadow's all the way over there, then it's probably a PA view. The patient's got his arms nicely rotated for you and everything looks pretty good. Secondary stuff. Now here we go, Radiology 301. Don't just look at it and say pneumonia, no pneumonia, done deal, moving on with life, right? I want you to basically window stuff down and I want you to look at everything. Remember, it's not all just about the lungs and the heart and then move on with your life. Absolutely not. I want you to window down and I want you to start looking at the vertebral bodies. Look at these guys. Look at these pedicles. Look at these pedicles. I want you to start looking. Do you know how many times on a chest X-ray I've zoomed in, windowed accordingly to the vertebral bodies, and I've caught some sort of irregularity that I recommended additional imaging, and it actually ended up being osteomyelitis. That can happen. That's not something that happens every single day, but I promise you, you'll look like a superstar if you find it, all right? So, the big thing that everybody loves talking about and everybody loves looking for is that pneumothorax, all right? If you're looking for a pneumothorax, once again, you know my view, right, on windowing. So first of all, you better be windowing. Your mouse should be doing this at all times when you're looking at a chest X-ray. If you're sitting there and you're just looking at it like this and you're interpreting something, I'm sorry, you're gonna be missing stuff. My spiel, real quick, for people who haven't seen my live sessions before, please, 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 describe everything before you jump to a diagnosis. I know some people may be tired of me saying this now, but describe absolutely everything before you jump to a diagnosis. Oftentimes your gut reaction is right, but oftentimes you will get confused and it will be wrong, or it will put you in a little box and you can only think about that one thing that your mind jumped to and you will not think outside of that box. So describe everything before, all right? So that one big thing that we were talking about before is a pneumothorax. So here we go. Remember, you're not just looking at it like this, you're windowing and zoom. Absolutely zoom. Not manually zoom. Don't shove your face like to the front of the monitor and start looking for something. No, you're gonna window and then you're gonna zoom up and you're gonna say, all right, where's that pneumothorax? Let me see. And I don't see it there. Let me go to the side here. And I'm gonna start looking for abnormal lines. I don't see anything abnormal. All right, let me go to the other side. Do I see anything here? No, actually it looks pretty good. I don't see any abnormal lines. Remember, the pneumothorax, the thing that you're looking for is, first of all, like I just keep saying, is some sort of abnormal line. And then you need to see these lung markings right here? See these right here? If they abruptly stop and you don't see anything beyond that abnormal line, then start being worried about a pneumothorax, all right? So that is a frontal view of a chest X-ray. Last thing that you can look for real quick is make sure there's no free air underneath. A lot of people, and you will do this too when you're interns, when you're residents, attendings, if you think somebody has free air, you'll actually order a chest X-ray, an upright chest X-ray, because you actually catch the hemidiaphragms really well with an upright chest X-ray. Remember, guys, I said, look at your lines, look at your angles, make sure everything is sharp, well demarcated. If it's not, if I don't see these left heart border and the right heart border, or if I don't see this nice angle, this nice angle, this nice angle, this nice angle, this descending aorta right here, this nice line, if I don't see anything, I need to start figuring out why. Let's move on. Man, I'm talking a lot right now. I'm about to drink some water. If I move on to the lateral view here, all right? So what good is a lateral view? My spiel before is when I was a medicine intern, I had no clue what a lateral view was for. I thought it was a waste of time. I didn't really appreciate it then. Now as a radiologist, I appreciate it 100%. Why? Because there may be something hiding on that AP view or that frontal view, the chest x-ray, that I just can't see, all right? What I want you to ingrain into your head, do you see this density of the heart? Do you see how it's not the most dense and I can kind of see through it? That's normal. Ingrain this into your head. This is normal, 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 all right? Because there may be stuff hiding behind that heart or around that heart that you just can't see because the heart is kind of covering it up, all right? So you go to the lateral view here. Now check it out. We'll go over all the lobes and everything. I got my presentation all geared up, ready to go for you guys. But this right here is normal. You want a nice white spine up here, and then as you go lower, 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 it should get darker and darker. Now tell me, you already know this patient was rotated on the AP view. Is this patient rotated on the lateral view? I'll give you 2 seconds while I drink some water. All right, 100% rotated. How can you tell? Look at this costophrenic angle, or this angle back here. I shouldn't say costophrenic, but see this angle right here and this angle right here? They are not correctly overlapping with each other. If this were a perfect lateral view, you should see only one angle right here, and that's it. Number two, the big thing, I already told you, right? I told you that this whiteness should be white, and as you go down, it should get darker, darker, darker. These two should be overlapping with each other. The next thing that they love to test you on is which hemidiaphragm is which. Which side is the left? Which side is the right? That's for you to try to figure out, right? So don't tell me about the, I just went over this too with a bunch of you guys earlier, but don't tell me about the stomach bubble. Don't tell me about which one's higher, which one's lower. Don't tell me about all that stuff. I want you to tell me which one can I draw from here all the way to the front, and which one can I draw from here, and then it stops about halfway. And why would it stop halfway? Well, because the heart is on that side. There's something called silhouetting. That's a fancy radiology word, and it basically means if there are two densities that are about the same density and they're right next to each other, well, they're gonna blur each other out. That's silhouetting. You can have summation. What does summation mean? Well, there's two densities. They're not exactly about the same, but when you put them together, they just become a little bit brighter, a little bit more dense. So that's a summation sign, but the silhouetting is what I'm talking about. So that's what you're looking for. If you see a hemidiaphragm and then it stops and then you can't really see it go anterior anymore, that's because the heart is silhouetting it out. All right, don't forget, by the way, you still are responsible for this spine. So you better you better be looking at all this stuff right here. You will catch fractures, you will catch osteomyelitis, you will catch stuff, so you are 100% responsible for that. Some people may ask, what's all this tissue right here? Well, when we take x-rays, or when the techs take x-rays for these patients, they have their arms up like this. So that's what this is what the soft tissue is right here. This is the heart. Anterior to the heart, this better be a little bit dark. If it's not, you got some issues. You better be figuring out why. Posterior to the heart should be dark. If it's not, you better figure out why. This is all your hilar vasculature. This is your pulmonary arteries, your bronchi. Don't worry about which one's which, but this should be a little bit busy. If it's too busy, if you have some actual some opacity, some roundness, some fullness here, well, you better be worried about some sort of adenopathy. You see your trachea coming down here. That's pretty much the lateral view. Any questions on that before we get to some actual cases that do have pathology on my PowerPoint slide here? Anybody have any questions that I can field for you? Let's turn this around. Who's got questions? You know me, I always gotta stay hydrated when I'm doing these. Are we good? We're ready to move on to the, we're gonna take everything that we just learned, all the normal lines, angles, everything. We're gonna take all that, we're gonna apply it to now the cases that I have prepared for you guys, all right? Here we go, let's flip that boy around. Intro to chest x-ray, how to tell which part, I got a question, how to tell which part of the diaphragm is right or left. So remember, once again, the left side, that's where the heart is gonna be sitting on this side. So the left side on the lateral view will not go all the way from the back to the front. The right side doesn't have the heart, so it will go all the way from the back to the front. That's how you tell. So here we go. Intro to chest X-ray. Like my dictaphone, that's what we do. 12 hours tonight that I'm just going to be working on. So this is, there we go. These are my lines and angles that I keep harping on right here. You better know these. You better be looking at every single one of these. If you're not, then you're not reading a chest X-ray correctly. So look at the green arrows, costophrenic angles. Blue arrows, cardiophrenic angles. Yellow arrow, that's my descending aorta. I see that beautiful, nice line. Look at the red arrows, right and left heart border. Remember which side's right, which one's left, right? You better be looking for every single one of these sharp lines and angle. If it's not, you got some sort of pathology, you need to figure out why, all right? Spine sign. Remember I talked about it should be getting bright, dark, 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 dark. If for some reason it gets bright again down there, you have some sort of pathology. That's pneumonia. Those blue arrows are pointing out a bunch of pneumonia, and that's called the spine sign, all right? Next, here we go. A lot of people love talking about it. Lobes, lobes, lobes. Okay, so you can see everything's all nicely written out for you guys. The yellow, minor fissure, minor fissure, minor fissure, red, major fissure, all right? Right upper lobe, right lower lobe, right middle lobe. These are the main ones that you need to concern yourself with. Then you need to figure out, if I don't have a lateral view, how do I know if the pneumonia is in the right lower lobe or the right middle lobe? Because look, Armored only labeled right upper lobe and right lower lobe. So what's up with that? Remember the lines, right? So if I have this nice line right here, but if I have some sort of opacity right here and it's now silhouetted out this portion of the hemidiaphragm, well, I better be concerned about a right lower lobe pneumonia. If I have this nice demarcated line right here, the right heart border, but if I had an opacity that now has silhouetted this out, well, I better be concerned about a right middle lobe pneumonia. Yes, there are exceptions to the rule, but for your point of view, just go off of this. This is your rule of thumb from now on, all right? Next, case 1. Y'all ready for this? What do we got? Anybody want to shout it out? This is interactive. Normal, badness. What else? You want to repeat? Tell me. I'll give you guys 2 seconds, and I'm going to move on. This is a 2-parter, so let me get you the next portion, the next part of this examination. Here it is. All right, what this case is about is stressing a point to you. This is inspiration versus expiration. This is the same patient about 1 minute apart. Look at the inspiration here. Nice big breath. The hemidiaphragms move down. The mediastinum looks all stretched out. There's the borders of the heart looking good. The opacity that I told you about of the heart, it's not super bright, not super dark. It's kind of see-through. And look at expiration. He's exhaled absolutely everything. And now look, everything's kind of up. Everything's squished apart or squished up. Look at the heart actually looks even enlarged. I'm telling you, I'm not joking. This is 1 minute apart, inspiration versus expiration. Your job to figure out, was this even a good examination? Did the patient even give an actual attempt to try to inspire on this examination? If not, it's going to look like this. All right, next case. Case numero 2. Oh, everybody's favorite question. Your attendings will love this. Which one, so this is a complete lung whiteout. Which one is a pleural effusion and which one is a completely collapsed lung? I'm going to give you about 10 seconds to figure this out. All right, I'm impatient. That was only about 5 seconds. Here we go. How do I know which one is which? Please, if there's anything that you remember out of my talk, this whole whatever half an hour so far, is remember this, because I'm not joking. People will look at a completely collapsed lung and try to put a chest tube in it. Don't do that, all right? So let's put the labels up for you. Effusion and collapse. All right, why is that? First of all, let's deal with this because this one's easier to see. Let me get this. There we go. All right. Look at the trachea. Look at the trachea. Do you see how it's really indented and it's being pulled to that side? All right. The way I like to describe it is there's some sort of bronchial, maybe the bronchus is cut off, there's a mass, there's a mucus plug. Something has caused the airway to completely collapse down. So there's loss of volume on that side. So it's gonna suck everything towards that side. It's a negative pressure, it's a vacuum. It's gonna suck everything towards that side. So here are the hints that I want you to look at and take home. when you're looking at this. Number one, the trachea is deviated and pulled that way. Number two, look at the whole mediastinum. Where is the right heart border? You don't see it, right? Because that thing is shoved all the way over there. It's pulled all the way over there. So number one, I had the trachea shifted. Number two, I have the whole right heart of border is basically shoved over that way or pulled. I should be using the word pulled. Number three, look at the rib. Look at the spacing of the ribs on this side and compare it to the spacing on the other side. Do you see how there's less spacing on this side than this side? Because again, everything is crunched down. Everything is sucked into like that little pocket of that negative vacuum. Now compare it to this side, all right? Trachea is not going that way, right? This guy is shifted, remember? Because look at doing one of these. Look at the spinous process right in the middle. So he's rotated a little, right? So I have mediastinal shift that way. I don't have anything going that way at all. So this is a large pleural effusion. Look at the ribs on this side and compare them to this side. They're spaced out wider on this side than this side. Large pleural effusion, complete lung collapse. If something's equivocal and you can't really tell the difference, don't just go and order a CT. Go be proactive, get the ultrasound machine, go up to your patient in the ICU, go slap the ultrasound on the patient's back and say, hey, this is fluid or this is not fluid. It's easy as that. You don't need to go down and get the CT. Case number 3. Ooh, what do we got? I'm gonna give somebody legit 10 seconds to figure this out until I give you the answer. All right, here's the answer. What did I tell you the last thing that I look at on a chest x-ray is? AC joint separation. Look at the bones. Did you see that? Or were you too focused on the lungs and the heart and the lines and the angles? Don't ever forget, there are bones on a chest x-ray. That's why I said I window down to the vertebral bodies. I window to all the different bones and I look. This is an AC joint separation. We can go over this sometime. This is not a shoulder dislocation. I repeat, not a shoulder dislocation. The AC joint is separated. There's an injury to the joint itself. Case number 4. What do we got? Who wants to call it out? Normal, next. Somebody's gonna say heart's a little generous. Okay. Is this an AP or a PA? Anybody? 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 What did I tell you about the clavicles? Where's my mouse? I don't know, there it is. What did I tell you about the clavicles? I don't know if you can even see the mouse. But remember, the clavicles are in view. Clavicles are in view. And it says portable and it's kind of cut off. Portables are usually not PA, right? So this is an AP view, remember, because the clavicles are in view. You can really see them. So the patient's arms are not kind of, out there. So it's going to accentuate the heart a little. So now I'm taking into account, okay, this is an AP view. The heart is a little accentuated. So, all right, I'm going to let that pass. Anything else? You guys want a lateral? It is chest x-ray view, right? Here's the lateral. Now what do you see? Yeah, now everybody's eyes go to the lines and angles, right? Look at, something's blunted back there, right? You don't see those sharp angles back in the spine and the hemidiaphragms. Now you ask me, hey, Amrit, did you see this on the AP view? Absolutely, I did. This is a posterior fusion. Here it is. Did you catch this? Did you see this little meniscus right here? This line? This is a posterior fusion. This is where fluid hides. You can have 100, 200 cc's of fluid back there, and you'll never know it. So remember, look. You can still see pleural effusions on an AP view, even though you don't have a lateral, and it's hiding back there. This guy got tapped after, and he felt a lot better. Case 5. Please tell me you guys see the abnormality because I have stressed home. Lines and angles, lines and angles, lines and angles. Tell me you see the abnormality. What line can you not see and what angle can you not see? You can't see the right heart border, that line, and you can't see the right cardiophrenic angle. What am I talking about? That right there. Where's the right heart border? It goes from here, and it stops. And then where's this cardiophrenic angle? Remember that? I don't really see it, right? What did I tell you? Ooh, somebody mentioned continuity of the diaphragm line. Good guess, but I see the diaphragm stop right there, and I don't see it crossing the spine, so I'm okay with that. But what did I tell you? That if you don't see the right heart border and something silhouettes it out, what pneumonia, what lobe is that likely going to be? You guys remember that? Right middle lobe pneumonia. All right, now you see it? Silhouetting. I don't see the right heart border. Next case. Man, you guys are experts after this. Telling you. Case 6. All right, tell me now, what do you see? Lines and angles, lines and angles. You're looking at everything. Somebody may be like, hey, the right costophrenic angle, can't really see it. Fair enough, I can't see that. All right, may have an effusion there, but I can't see. Good, good, good. What else? What else? Secondary clues, just a side tangent, because you know I love going on tangents. AP view or AP, or is this gonna be, I can't speak. Is this an upright or is this a supine view? Just look at the stomach bubble. Air up here, fluid down there. So where, that was just a tangent, but where's the pneumonia on this thing? You want a lateral view? Of course I got a lateral view for you. All right, where's the pneumonia? Do you see it? You see it, you see it? Right upper lobe pneumonia. Where was it? Right here. Do you see this minor fissure? I told you where the fissures were, right? What is this opacity right above it? Why is there a nice line right below it? What's up with this? What's going on here? Why is this way too full? I told you, right? Remember, if it's way too full, there's something going on here. So this is right upper lobe pneumonia. Case number 7. What do you guys got? Go for it. Tell me. Tell me, tell me, tell me. Lines and angles, everything looks pretty good, but now I want you to train your eye. Where is there just too much white stuff? Where is there just too much opacification? Do you guys see it? Do you see it now? Yeah? You see it right back here? You want to go back to the AP? See this right lower lobe pneumonia? Here it is. This is way too much. Yes, the hemidiaphragm you can see, but why is there so much opacification right there compared to the other side? And then what the hell's going on back here? I told you, first of all, you better see a nice angle back there. There's way too much opacification. I said which one was right middle lobe. Remember that thing in the front or the beginning of my talk? Right middle lobe was over here, right lower lobe was over here, right upper lobe was over here. So I'm correlating this to this. It's right lower lobe. Case number 8. What do you guys see? Oh, yes, here we go. This is a tough one. This is a tough one. This is a tough X-ray. It looks a little like kind of ratty. I don't know what's going on. But remember when I kept harping on, look at the heart. Make sure you see that it's not too opacified and it's not too lucent. It's kind of intermediate. What do you think about this heart? What's this? Why does it look like it's kind of going over here? What is this going on right here? Something's weird going on, right? Let's go to the lateral view. Do you see it? Anybody see it? Anybody see it? This is the heart. What is this? Can you humor me right now? Is this an air fluid level right here? This is air, this is a line, and this is fluid down here. Why would you have an air fluid level and a bulbous type configuration behind the heart? Hiatal hernia. Here's the heart. Here's the stomach going through the diaphragm, through the crus, and it's sitting posterior behind the heart. Hiatal hernia. You will see these all the time. All right, you guys see it now? Right here, hiatal hernia. Next, case number 9. What do you guys see? Shout it out, shout it out. Let's do it. I'll give you 5 seconds. Let's get those thumbs typing. 3, 4, and 5. Here's a lateral view. Anything? Anything? Breast shadow. Did you guys notice, or did anybody start looking at this right here? And they're looking at this right here and they said, I don't know, there's like too much stuff going on right here, right? Maybe it's kind of silhouetting out here. Is there something going on here? It looked too full here. But then you got a lateral view and you're like, I can't really correlate it to anything on the lateral view. Well, it was the breast tissue. So remember that. If you have a lateral view, you can correlate things. You can kind of, I don't want to say triangulate because you got 2 things, but you can figure out what it is. So remember, you have soft tissue that you need to deal with as well. Case number 9, I think this is the wild card now. I think. Yeah, this is the wild card. Who wants it? Who wants it? Who thinks that they know chest x-rays now? I can tell a lot from this examination right here. An absolute lot. Remember, anybody's heard me talk before, radiology is a puzzle. I don't just diagnose A and then I diagnose B and I don't try to correlate those together. That's not how I work. I look at A, I look at B, I look at C, I look at D, and I go through down the alphabet and then I try to figure out how do they all connect together. All right, so let's break it down, shall we? First of all, I'm looking at the just kind of general gestalt of the X-ray, there's just way too much going on. I don't know what's going on with this patient. It's just so busy. Heart's doing something. The hemidiaphragms are doing something. I don't even know, right? Let's break it down. Yes, I'm glad somebody said pulmonary edema. Pulmonary edema is a hard diagnosis to make. It is something that is tossed around a lot when people are reading chest x-rays, but it actually can be a very difficult diagnosis to make. We can go over that at one point, but and I'm glad you said that, because this was originally read as pulmonary edema. Okay, so you have a lot of stuff going on here. There's some interstitial markings, some increased interstitial markings. Don't worry about the terminology. You don't see the angle here, the costophrenic angle. It's a poor inspiratory effort. Look at how shallow the lungs are. The heart looks accentuated. Just so much going on here. Let me window it one more time. And do you see anything different now? There's no pneumothorax, everything's okay. Yeah, I agree, there are some effusions, absolutely. What I want you to start noticing, and again, now this is Radiology 401. If this is somebody who's read a lot of chest x-rays in their life, and they're gonna start piecing this all together. Number one, yes, like we mentioned, there's a lot of schmutz going on here. There's some interstitial markings, could be pneumonia. Yes, we said there could be a pleural effusion here, absolutely, absolutely. But what I want you to look at is the bones look really ratty right here. They're kind of like patchy areas of sclerosis, some lucencies over here as well. Let me go back to the other, there we go. The bones look really ratty to me. Something going over here, something going on over here. The other thing, look at the breast tissue. Look at the breast tissue. Do you see this breast? And then do you see this breast right here? So start putting things together. You have completely asymmetric breast tissue. You have some abnormalities in the bones that are kind of ratty. They're kind of patulous. There's some sclerotic areas. It's bad. And the majority of the opacification, that just junk, is in the right lung, where there's an asymmetric breast that's really shrunken down. This is a sequelae of breast cancer. All right, this patient had just infiltrated breast cancer, and there is a CT afterwards that the patient got. There was lymphangitic of the cancer into the lungs, spread of cancer into the lungs, and the breast was completely shrunken down. This is all metastatic disease, all mets throughout the bones, everything. So this is, again, Radiology 401. This is an exam that I wanted to really include, because I wanted you to realize that when you're reading a chest x-ray, it's not just pneumonia, big heart, effusions next. You put everything in perspective. So you got to look at the whole picture. You got to piece the whole puzzle together. You are a detective. You are the radiologist. When I read exams, I'm not just sitting there next. I'm putting everything together. Breast cancer, Mets. I believe that's all I got for you. Let's turn this around. How'd you guys like that? I talked a lot. That was like a 45-minute thing. But did you guys learn a lot? Whew. What would be the script info for this? Script info for this, what do you mean by that? As in prescription? What else? Did I miss anything up top? Any questions that I can answer for you guys? The other thing that I want, this is gonna go on for 24 hours on Instagram. I've had issues with uploading it in the sound before, in the whole last week, which is friggin' annoying. We'll see if it works today, but as always, this is going on to YouTube right after this. I brought my laptop to work. I'm gonna upload this right now. If you don't know what my YouTube account is, just go into my bio right now. I got two little fingers like pointing down to the YouTube account. Click on it, go subscribe, and go just check it out. I want this to be your framework for reading chest x-rays from now on. Do it. I promise you, it's gonna help you. It's gonna get you out of a bind. If you ever have questions, you know you can always message me, ask me, let me know what's on your mind, and we can go over the next thing. If you want to go over KUB, we'll go over KUB. If you want to go an abdominal CT, we'll do it, all right? Once again, I talk like crazy. I just go on tangents. I drink a lot to stay hydrated, but I love you guys. I appreciate it a lot, as always. We'll pick this up again. Thank you guys for checking this out. It really means a lot, and we'll do it next time. Later.